Hello, Sam. How are you?
Hey, Clint. Good to be with you.
You too. So today we're talking about Achilles tendonitis. We're going to cover all that one,
Yes.
sort of talk about what the basics are, how it can be treated. So
Yep.
this kind of thing where if anybody's suffering from it, they'll know a bit more about it. Probably good
hmm
information for GPs. We just want to get a few extra pointers and such if you guys
hmm
have somebody coming in. Now, I'm assuming most people probably know what this is, thanks to the story of Achilles. But let's
hmm
actually go over it anyway. What is the Achilles tendon?
Well, the Achilles tendon is basically a connective tissue, Clint, that it basically connects your calf muscles, which there are two calf muscles, your gastrocnemius and your soleus muscle, to the heel bone. And basically, what the connective tissue acts to do is, as it connects to the heel bone, when these muscles contract, it allows your foot to what we call plantar flex, or allows you to point your toes down, basically your foot down. So it's really important for any position, any time you want to have that position where you're pointing your foot down. Most important of which is when we're walking and we're pushing off in that propulsion phase of gait. You're pushing against the floor or the ground to sort of enable you to push off. So if you think about people doing an average of say 5 to 15,000 steps a day these days, it's being used a lot.
Mm.
So that's the main function of the Achilles tendon.
Yep.
Or the
So it's the tendon at the back on our heel, but you're just
of the
saying it's
heel.
actually one tendon, two muscles. Is that right?
Yes,
Oh, how about
both
that?
muscles come into that one tendon, and it's made up of collagen fibers.
Mm-hmm.
It collagen fibers which are really really strong because they're in a parallel alignment. So
Yep.
they're imagine a band of wires in parallel alignment.
Yep.
Makes it really really strong for that strong and stiff energy transfer when you propel in the propulsion phase.
Gotcha. So now that we're all on the same page with what the Achilles tendon is, what is Achilles tendonitis?
Achilles again, very similar to our plantar fasciitis, fasciopathy
Mm-hmm.
chat. The basically, if we said Achilles tendonitis, we're assuming that it's inflammation of the Achilles tendon. So that's the tendonitis part, but it can also, very similar to the plantar fascia, it can become degenerative, and that could be called tendinosis. But typically, we lump them together into that tendinopathy term, which is basically interchangeable for the purposes of a common chat like this.
Just to understand that difference, so if somebody has tendonitis, they'll be feeling pain, but they're not necessarily likely to suffer any injury. But if it's tendinotis, then it is actually degenerating and they could be weakened and they're more likely to suffer injury. Is that fair to say?
Yeah. In a roundabout way, we'd say that tendonitis is just exclusively inflammation. It might be just very early on. Something that's been aggravated, it's been overused slightly, it's inflamed. There's no degeneration there. It's not a chronic sort of a thing. It's just something that's inflamed that would respond really well to their typical anti-inflammatory measures like your ice, your rest, things like that. Whereas the tendinosis part is more where, if you were imaging that tendon and you found that we were starting to not just have inflammation, but you could still have pain, but it's typically later on down the track that we would assume that tendinosis might be a factor. But like I said, very interchangeable terms, and we'd lump them all together into this tendinopathy part where we're not really sure if it's, and we don't need to be sure whether it's just inflamed, a bit degeneration. We need to tailor the treatment plan to treat both of those, and we're going to see how the person's progressing anyway before we sort of make any determination of whether we throw in imaging or any specific measures for to fix the degeneration, things like that.
Gotcha. And so what causes it?
Yeah. So before I go into what caused it, I'll tell you those two little things, because I know we're going to talk about treatment later on. So I just want to get in terms of the tendonitis part, or we said the tendinopathy part, they're a little bit different than the plantar fascia in that there is the two distinct phases with the tendonitis or tendinosis, tendinopathy, whatever we want to call it. The first part, the first phase is the reactive phase, and that we get a little bit of infiltration of cells into the tendon. The tendon can become a little bit thicker. So that's the tendonitis. You often hear people saying, oh, the tendon looks a little bit swollen, it's a little bit thicker. And then the next step would be what we call a disrepair phase. And that's when the tendon becomes a little bit more pliable, That's typically later on in the injury. A little bit more pliable, it's a bit softer, and the collagen fibers aren't in a nice parallel alignment anymore. So we sort of get a little bit of mismatch in there, and that means the tendon then loses its ability to be a strong energy transferer that we expect it to be. So that's really important for when we come to our discussion later on, that loosely arranged collagen versus the nice parallel alignment of the collagen. And also you can get bursa around that area as well, around the heel bone, that can become inflamed. They can mimic Achilles bursa, which is a small sac of fluid that sort of protects around the tendon there. There are a couple around there that people should watch out for as well, because sometimes they masquerade as a tendonitis, or they can be co-involved with a tendonitis. So that's important when we're saying what is Achilles tendinopathy. Typically, it's just pain in that little tendon around the back of the heel, but it can present in a few different ways, and that has important ramifications later on. And you were asking, sorry, why?
So it's a good, giving us a bit more of an understanding of what it actually is, which sets us up for what causes it.
Yeah. So the main thing is the Achilles tendonitis, tendinopathy. That sort of framework, if we're looking at that, typically it's going to be an overuse injury again. It's going to be something that's overwhelmed the capacity of the tendon to deal with the load. Now, it typically happens if we go through a typical cycle, it's going to be some sort of exercise or activity. Could be walking, could be running, could be things like sand running, hill running, changes in shoes with different pitches, things like that. Speed work that asks the tendon to do a little bit more than what it can. How the tendon usually works is we do this activity, we introduce the activity or exercise, we create a little bit of damage, micro damage, we call it, and then we need a rest. And then the body in that rest period adapts and increases its capacity to handle that stress that's applied. And then you repeat that process. And as you keep doing that, the tendon will keep increasing its capacity to handle the load that you're putting it under. Now, when we see an injury to the Achilles tendon, it's typically something in that equation that's changed. So we've overwhelmed the capacity somehow by doing too much or not resting enough and letting the tendon catch up and increase its capacity to deal with that.
Gotcha.
That's the main reason it'll happen.
So does that mean typically if somebody has developed tendonitis, it's probably well worth thinking what they might have changed in their lifestyle recently?
Absolutely. So
gotcha.
It'll typically be something that's caused it to do too much. So the overuse part, which is again changing shoes, especially changing shoes with a different pitch, a heel pitch. So when we say heel pitch, we're talking about the height at the back of the shoe compared to the height at the front of the shoe. Typically, that can be a 0 gradient shoe. It could be a 10 millimeter pitch, 13 millimeters, something around that. A change in that pitch will mean that the tendon is under different load. Hill running, very, very common. Sand running, very, very common. Speed work, where you're again pushing off with a lot more power. You're trying to do a lot more. That's putting a lot more load through the tendon. Now, things like that will definitely increase the load on the tendon. Then we've also got to look at the other part of that, which is that now that we've caused the damage to the tendon, have we given it enough time to rest and adapt to that load? So then we look at the rest periods. Are we cross-training, or are we doing, sequential days of high load repetitive activity? Things like HIIT training, where it's the high intensity, that sort of thing. And things like where we've just taken up a new exercise program, we're on a health kick or something like that, or we've gone from a period of rest to rapidly increasing activity. Things like that, definitely we should watch out for. So if somebody can isolate those things, it's very helpful to be able to pinpoint and say, oh yeah, I did this. And typically within a couple of weeks, the symptoms will progress. So you might say, a couple of weeks before I've done this, I've started a new job, I've started walking a lot more, things like that.
Gotcha. And that's quite nuanced, because as you're saying, we did something new. What first entered my mind was somebody, they've gotten a health kick, like you said. They've started running a lot and they hadn't beforehand. But it could be something as minor as changing shoes.
Yes.
They could have, from the sounds of it, even if you were to say move home and you're going for, say, a regular run, you're just running on it's a new path you're taking now. There could simply be something about that particular path that puts extra strain on your Achilles tendon that causes this as well. And I guess to further complicate things, you can't say, what did I do today or what did I do yesterday? You've got to think back about half a month, 2 weeks.
Mm,
Yeah, okay.
absolutely.
So that's right. So it can
Yeah.
really sneak up on you in a way then, can't it? Because, you could be,
It can.
you've moved home, you changed shoes or whatever, you've been running for 2 weeks, everything seems fine. And then all of a sudden it doesn't. So I guess, does that make it hard for people to sometimes pinpoint what the cause was? Do people need to sort of really sit down and think hard about what has changed?
Yeah, sometimes it is so commonly in the clinic, it could be because this is, we're introducing that micro damage. Like anything, it's the rate that you've increased that's going to dictate how quickly you see that. So if it was something that you had a really, really big weekend, that could be the stimulus for this reactive sort of inflammation phase, and then people will come in and go, I had a big weekend. Typically, if it was just something that short, it's going to be sore for a couple of days, and then within a few days it'll sort of settle. But the 2 week one is where we've started something and we've just kept on going, and then you'd say, okay, well, that one creeps up on you because it's not enough to cause an initial, oh my gosh, what have I done, sort of reaction from the person. It's more, this feels a little bit stiff today, or that tomorrow it might feel a little bit sore, and then a couple of days that should go away, but it's not. It's maybe getting worse, or it's staying, or now it's starting to affect my day. And typically that would be in that 2 to 3 week mark where people would come in and say, it's sore, I don't know really what I've done, because they're expecting it to be something they did yesterday or on the weekend. But then when you take their mind back to, okay, well, how about let's go back a little bit further in the timeline, typically they can say, oh yeah, I did do this, I did do that. And it might be something that they don't connect with it. Like for example, I did have a person who in the clinic not too long ago was saying that, took the daughters out to the beach because it was a nice day, took the daughters out to the beach, and they were running along the beach and things like that. And that's the aggravating factor. Before that it was sort of there at a low level, but this sort of pushed it over the edge. And it's only when you go back to the timeline and you say this and this and this could have caused it. Is there anything there that you can sort of resonate with there? And that's how we find that out.
So that was in a particular example, there was sort of a singular event that had a significant contributing effect. But there was also were there some other changes as well beforehand that were also contributing to it, were there?
Yeah, so this person had enough pain there to know it was there. And so typically how Achilles tendonitis, or whatever you want to call it, presents, it's typically that post-static dyskinesia or post-static pain, post-static meaning after periods of rest, or getting up in the morning, the first few steps after getting out of bed. Sometimes it'll settle during the day, sometimes it won't, sometimes it'll get worse, sometimes it'll, you thaw out basically, and it's only when you rest again and then stand up again that it comes about. So everyone's got a little bit of a different presentation of it. With this particular person, he had that low grade, little bit stiff when I got out of the desk, out of the chair behind the desk, a little bit sore in the morning, but then it sort of goes away. And then so you don't think too much of it. But this particular time at the beach, that's what threw it over the threshold where now it's really noticeable, and now with every step I'm taking, I'm noticing. So that's that micro damage without the rest period, and then just escalated that.
Understood. That is interesting. So obviously you feel the pain. I guess you're feeling it sort of around the back of the heel, maybe sort of around the sort of ankle area. Is that essentially pretty much the classic indicator, or are there other things that people should be keeping an eye open for to understand if they might have Achilles tendonitis?
Yeah, that is the classic indicator, having pain at the back of the heel. Typically, it's in the mid portion or the insertional part. So insertional part meaning just above the heel bone where the tendon inserts onto the heel, or that mid portion, which is between where the calf muscle starts and that insertion point on the heel, along the length of the tendon. Typically, the mid portion there is where we're going to feel it. Typically, we don't have great blood supply to that area, so it can be a niggling thing, can take a little bit of time to heal, especially because we are using it, like we said, 15,000 steps a day. Now, the hallmark, so like I was saying, it can be that people have that pain, for the initial, 10, 20 minutes of their day, and it warms up and goes away. Sometimes it will settle during the day, sometimes it won't though. The main thing that people, if you wanted a typical thing that will tell you, okay, this is Achilles tendonitis or not, is the presence of like a little nodule or a lump in the middle of that section of the tendon. So that mid portion, if we have like an egg-shaped nodule or a lump there where the tendon sort of comes out, you can feel and squeeze a little lump there. That's very, very closely associated in the literature with a positive diagnosis of Achilles tendinopathy. So that one, if you can feel that, you definitely want to get that checked out.
That actually sounds a bit scary. I've never experienced anything like that before.
Not too scary, but it's a one of those tests that you can do yourself where you can feel the tendon. If you can squeeze the tendon and it's sore, you definitely want to be able to check that out, because especially if it's not, if you're massaging it, it's not going away. Or like we talked about before, if it's something that is just plateauing and lingering and it's there, or it's increasing in magnitude, intensity, frequency, duration, things like that, definitely get that checked out. But if you find that egg-shaped nodule, that is highly, highly associated with the diagnosis of Achilles tendonitis.
So pain's a pretty good indicator. But any kind of, any stiffness, swelling that you can feel is a real serious indicator. And like you said, stiffness as well. So pain and stiffness, probably got it. But any kind of like swelling or something like that's off to see somebody for help. Gotcha.
Yes.
So imaging is, from the sounds of it, it's fairly easy to diagnose from just a regular inspection or asking a few questions. Is there a need for imaging or anything like that?
No, you're exactly as you said, Clint. It's typically a clinical diagnosis, and a lot of times you'd have a pretty good idea if you've got it yourself, because you're experiencing those symptoms and you can feel it, you can see it, or you can feel it as you're springing forward, as you're walking. The stiffness that we're talking about. But if it's something where we've got that, like that egg-shaped nodule I was talking about, sometimes we would image that just to rule out further instances of like things like tears, if you've got a tear in the Achilles or something like that. Or typically if it's not responding to our treatment plan. Very similar to a lot of other things medically, when we look at things and we say, okay, well, if it looks like this and it should respond to something like this, and it does, then we're pretty comfortable with the way that person is being managed. However, if it's not responding the way we'd want to, or we want to clarify the diagnosis before, if it's going to change our approach to treatment for that individual, or if it's going to help us clarify something before we go down the path of a certain treatment modality for that individual without wasting time and money, and importantly that window for healing, then we would image that. But in general, no, we'd consider that more of a clinical diagnosis initially. Yep.
So I guess if you're a patient and you've shown up with what you think is a lot of pain in your Achilles, and I guess most people, we can see our Achilles, we know exactly where it is, and so you can sort of practically touch the point where it hurts. So I guess most people would feel pretty confident that they know that it's something to do with the Achilles. But unless there's some kind of a growth or something like that, or it's been persisting, you shouldn't be worried that you haven't been sent off for imaging by whoever.
No, absolutely. You shouldn't be worried. You shouldn't be worried if you haven't been sent off, unless, like we're saying, you've been doing the treatment for a little while and it's just not getting anywhere. Even if you've been doing self-treatment, to be honest, if you've been doing self-treatment and it just isn't responding, then then you'd say, okay, well, why is that not or not behaving the way it should?
Or if we feel there's some kind of a growth or something, just to be on the safe side.
Absolutely. A growth, definitely. Absolutely.
Gotcha. So you mentioned treatment there, and how if treatment hasn't been taking and hasn't been sort of correcting the situation, how do we treat it?
Well, if we think about earlier on how we were talking about that overuse thing, the exercise inducing some stress, relative rest, and then we want to give the body time to sort of adapt to that load. The treatment is basically about load management, or the mechanical treatment anyway is about load management or modification of the load going through the tendon. So we would introduce cross training and slowly resume the loading as the tendon becomes a bit stronger, because remember our chat earlier about how the collagen fibers at the start, they should be nice. If in a good strong tendon, it should be stiff with nice parallel alignment of the collagen fibers. As the tendon becomes a little bit weaker and becomes a little bit more damaged, we don't have that alignment anymore, and the tendon is now a weaker structural member, essentially. So in this case, we can't just rest and say, okay, well, that'll feel better or that'll get better. the rest part might make you feel better in terms of, and that's a big takeaway actually, that some people come in and they say, well, yeah, for the last 2 weeks I haven't run, or for the last 4 weeks I haven't run because it hurts and it does feel better. Now that's good for the actual pain management part of it, but the tendon itself needs to be stressed and become a bit more stronger. So adapt to that load for you to be able to get back to the full load. So the treatment will essentially be relative rest rather than actual rest. So we don't just stop. We want to improve that. So we can do things like massage. People do things like self-massaging, and that's great. But essentially, the hallmark of the treatment, or the keystone of the treatment pathway, will be initially to reduce the load on the tendon relatively. So typically we'd use things like heel raisers, or have shoes, or increase the pitch of the shoe. So shoes with a little bit of a heel, that will help by reducing the tension or the stress on the load on the tendon. So that's the first thing that we would do. Orthotics would only be used, even temporary orthotics would be used if we need to improve the mechanics or the biomechanics of the person. So again, that the tendon isn't working as hard through the day when we're taking those 5 to 15,000 steps a day. But then we'd need to improve the capacity of the tendon to, bring that person back to be able to handle the load they need. We do that typically with eccentric exercises. So contraction while the tendon is lengthening. And typically we do that with, people will do it on a step, just reducing, standing on a step and just lengthening that tendon. So you'd be lowering the heel a little bit like that, under controlled lowering the heel. That will strengthen the tendon. I would normally advise people to do that under some sort of management, though, so that if you're doing it on a tendon that can't handle that, or you're not ready to do that, you can be causing further damage. But definitely eccentric exercises, some sort of lowering gently over a step will be very, very helpful. And then things like shockwave therapy again, PRP injections again, things like that. Later on, if we're not responding, or we need to speed up that healing, stimulate that healing.
Gotcha. So it's mostly exercise, but there might be other treatments if it takes too long. So I guess that brings in another question: how long does it usually take to heal?
Yeah, and this one's where I was saying earlier that it's going to come back to being pretty important for us. Where it really depends where we see it, Clint. So it depends if it's in that initial phase, the reactive phase, or if it's in that disrepair phase. So if it's in the reactive phase, or it's just that inflammation initially, there's been a period of overuse, something's gone on, you've moved house, like you said, a lot of stairs, things like that. And then we've reduced that load. This tendon is still strong enough. It hasn't been damaged enough that the fibers aren't too far away from parallel. So the tendon is still strong enough. Then something like that, we would expect between 2 and 4 weeks, a treatment plan. So it's pretty quick. But if we see it later on where the tendon has become a little bit damaged, we're getting that degeneration of tendon, the tendon isn't as strong as it used to be, and we need to build that back up, because that's very important to build the strength of the tendon up so that it can now have the capacity to handle the loads we want to put it through. That one can take between 8 and 12 weeks, usually, if everything's done correctly. So it is a multifactorial treatment plan when it becomes that. It's not as simple as saying, we'll just modify this and you should be okay in a few weeks. So really, the takeaway for the Achilles is it can become a very frustrating and very long treatment plan if we let it go too far. So the main takeaway for it would be that if it's not responding to something that you're doing initially, the self-massage, the modifying the load, cross-training, things like that, heel raisers, or wearing a shoe with a heel. If it's not responding within a couple of weeks, it would be the earlier you can get it seen to, the quicker it's going to go away and be able to save you a lot of delay in the loading, in the treatment sort of.
So stitching time saves 9, as they say. So I guess it's possibly something that you see a lot where people, they notice it and they think, I'll see how it goes. But I guess and we want to be careful about giving people advice on how to treat themselves. And if you disagree with what I'm saying, by all means say, no, Clint, no. But if anybody does sort of feel a little bit of stiffness in their heels, or in the Achilles tendon, doing some of those exercises, like you were saying, on the stairs, like standing on the stairs, lowering yourself, lifting yourself, lowering yourself. I mean, they strike me as fairly good exercises to do anyway. I think when we spoke about plantar fasciitis, you were saying that, like, what's wrong with having more flexible calves? You know, just do some exercises around that area to help anyway. That's probably not a bad exercise for people to do now, I guess, to help prevent Achilles tendonitis. Would it be advisable for someone to do that even if they're just like a little bit stiff in the mornings or something like that, if they're at that sort of stage?
No, there's no problem to do it. The only issue with doing any exercises is if you're not ready to do them, or if you're doing them too far beyond what you can handle. So that there obviously needs to be it's an individual approach, and it needs to be tailored to the individual in terms of how, there are some people that will do that weighted exercise. So, if the tendon's able to handle the load, then you can increase the load on it. It's no different than going to the gym and saying, bicep curls might be good for everyone to do, and that's fine. But if I'm going to go and try and lift 50 kilos all at once, I'm going to hurt myself. Whereas if I've been used to, if I lifted 45 last week and I was okay, then 50 this week, he's going to be fine. So it's one of those things that if you were going to start doing something like that, it is okay to do, but it needs to be done very gently. It needs to be done gently. And also the biggest thing I see in the clinic anyway with people that are self-treating or people that are following a treatment plan, even if I've given it to them, is we need to pay attention to the body's response to that stimulus. So, and typically that's the next day pain. So if you've done exercise that's gentle enough that it is stressing the tendon and you're giving it some rest period, you should feel okay the next day. So you want to stretch it and exercise it to the point where it could be a little bit uncomfortable. So point of discomfort is okay, but not to the point where the next day it really hurts. That means you've overdone it. And so in that case, I would advise people not to, you could try it gently. And if the next day you feel okay, that's a good level. That's okay. And then you can keep sequentially increasing that as we do with any other treatment program or any other muscle building exercise. You're always trying to stress, give your body a chance to catch up, adapt to that load, stress a little bit more, adapt, stress a little bit more, adapt. And that will strengthen the tendon, or the muscle or whatever you're doing. But if we're sore the next day and we've done too much, I'd advise to either cut back on what you've done, and then you can give it another go, or that's where you would seek some professional help, because it may not be ready for that and you may be causing further damage if we were going to, keep going down that pathway. Understood. So the pain the next day is the probably the biggest telling indicator of whether you should be doing it or not.
Very good to know. Okay, so let's just recap what we've done. I think we all know what the Achilles tendon is. Achilles tendonitis is essentially inflammation of the tendon. Tendinosis might be where it's starting to degrade. Typically, it's a result of overstressing the tendon itself. Most people know they've got it because they know where the Achilles tendon is and they know what that pain is like. But if you do notice any sort of swelling or anything like that, definitely get yourself off to see somebody straight away. And that's probably also where you'd want to see some kind of imaging or something like that. If you had something like that, or if it's taking too long to heal. And usually it's treated through some kind of exercise to improve the strength of the tendon. But you've probably done a bit too much if it's hurting excessively the next day. And if you catch it early, we can expect it to heal in about 4 weeks. Otherwise, if you left it a bit too long, it could be as long as 12 weeks. It can even be longer than that if longer. If it's But and the other important part of that is the treated through exercises, but load management is the really important one there. So that's stupid exercises. Exercises could actually take you the wrong way. Indeed. If we're not doing them correctly. So as you said before, as you in that summary, that was it's correct to say that we look at the next day pain, we look at the functional measures. So you're able to do more, that's good. If you're able to walk more and do more without pain, that means the tendon is getting stronger and it can handle that load. So that's the load management part, where, like we said, we don't want to rest completely. That would be going the wrong way. That would be actually weakening the tendon, so that when you did try and introduce an activity again, you're probably going to hurt it some more because it's not used to that. So we want to decrease a bit of load, but increase the the capacity of the tendon to be able to handle that load. And then we just keep matching those together as we go higher up the chain.
that then you're able to get back to walking and running and exercising and doing everything you normally be doing, because the tendon can handle that. We're actually safeguarding against the recurrence of that injury. So that's the really important part with the Achilles. And that's where people get really frustrated if they say, well, I've stopped running, or I've stopped playing squash, I've stopped playing footy, or all of that sort of stuff, but it's just not getting better. I still go for a 5-minute walk and it's still sore. And that's because we've done the rest part, but we haven't introduced that load management component. So that's where I think it's that important differentiation between just actual rest and relative rest and load increasing, load capacity building, basically.
Yeah, probably something a lot of people don't sort of think of intuitively.
No, the first thing people think of, usually when I see them in the clinic, is I've stopped running for 2 weeks, or I've stopped, whatever for 2 weeks, and it feels better. But now when I start running again, the pain just comes back. And then that's where it can become a very frustrating one, the Achilles tendon, because it's not something like a shoulder or something like that where you can put it in a sling and just use your other hand for a couple of days. With every step you're taking, you're actually re-stressing.
Understood. Excellent. Thank you for your time on that one, Sam.
Pleasure.
It's been very informative, and I look forward to talking to you next time.
Yeah, I'll catch you then.
Take care.